So we are going to discuss today the ATT induced hepatitis, its diagnostic criteria, and when to discontinue the ATT and when to restart it. So definition wise, we say patient is having ATT induced hepatitis when he or she meets one of the three criteria. The first one is if the patient is having sign and symptom of hepatitis plus ALT level of more than 3 times the upper limit of normal. The second criteria, if the patient is asymptomatic but he or she is having ALT 5 times the upper limit of normal. The third criteria is if the patient is having visible jaundice or significant rise in bilirubin, we label it also as a case of ATT-induced hepatitis. Now, if the patient meet one of these criteria, then what step we need to take? We have to discontinue hepatotoxic drugs from the first line for ATT and except ethambutol. The remaining three are hepatotoxic, including rifampicin, isoniazid, and pyrazinamide. Now, there is a scenario when you need to continue non-hepatotoxic anti-tubercular drugs. And what is those situation? Number first, if the patient is having smear positive pulmonary TB to reduce the chances of spread. Number second, tuberculous meningitis. Number third, if the patient is having severe disseminated tuberculosis. In all these three criteria or scenarios, you have to continue non-hepatotoxic ATT, which includes ethambutol from the first line and streptomycin and respiratory fluoroquinolones from the second lines. Now, when should we restart the hepatotoxic ATT? So the criteria is to monitor LFTs every 3 to 7 days, and when its ALT level drops to 2 times the upper limit of normal, then you can restart the ATT. But the order of restarting should be the least hepatotoxic to be started first, followed by the isoniazid and pyrazinamide, which are more hepatotoxic compared to rifampicin. So the first to restart is rifampicin, followed by isoniazid, and then last to be started is pyrazinamide.